In this section of our longevity education series, I want to cover an area that generates a huge amount of confusion and increasingly misinformation, and that's the role of molecules in longevity medicine. I'm Dr. David Samra, a specialist sport and exercise medicine physician, and at Progressive Longevity Clinic, we spend a lot of time helping patients navigate decisions around supplements, medications, hormones, and newer agents like peptides. The goal of this section is not to promote or dismiss molecules. It's to place them in the correct biological and clinical context so patients can understand where they add value, where they don't, and where they can actually cause harm. When used well, molecules can support outcomes, but when used poorly, they distract from or even undermine the foundations of health. If you look at elite performers, whether they're athletes, military, or high-functioning individuals, you'll notice something consistent. Their outcomes are built not on supplements, they're built on behavior. Training consistency, recovery strategies, nutrition, sleep, and discipline form the base. Molecules may be laid on top, but they're never the driver. And this becomes important because modern health culture often reverses that hierarchy. Now, at the other end of the spectrum, we see individuals using increasingly aggressive pharmacology to drive outcomes. And while some of these interventions can produce visible short-term changes, they often come at a physiological cost, particularly to metabolic health, mental health, cardiovascular risk, and long-term function. So the question is not, do molecules work? The question is, at what cost, in what context, and compared to what alternatives? This slide summarizes the entire philosophy. You need to bake the cake first with all the components of health that we've discussed in this series: sleep, strength, cardiovascular fitness, and emotional health. They form the layers of this cake. These are the systems that determine resilience, metabolic function, and long-term health. The molecules sit on top as icing. They can enhance, support, or fine-tune, but they cannot replace the structure underneath. And if the foundation is weak, adding more molecules doesn't fix the problem. It often just hides it temporarily. So there's an important distinction here between what patients can control and what we prescribe. On the left is internal: behavior, consistency, and discipline. On the right, medications, targeted therapies, and adjuncts. And our role as clinicians is to prioritize the internal control first, and then apply external tools where it's appropriate, not the other way around. Now, one of the challenges we have in modern medicine is that we often overcredit drugs and undercredit lifestyle. And at the same time, the supplement industry frequently overstates the benefits and understates risk. And many products are marketed ahead of the evidence. So this creates confusion for patients who are just trying to do the right thing. Our standard at Progressive is simple: precision, evidence, and clinical clarity. We take a clinical approach, not a commercial one. That means no conflicts, no trends, and no shortcuts. So how do we actually approach molecules in practice? We use a structured framework. This is the same framework we use in specialist practice, not just for longevity patients, but across all clinical decision-making. The first thing is risk. Before anything's prescribed, we need to consider interactions, contraindications, and of course, unintended consequences. Secondly, lifestyle opportunity. We ask, is there a behavioral intervention that would achieve the same or better outcome? And often the answer is yes. Third, the evidence level. Is this supported by high-quality data, or is it early stage and theoretical? Fourth, therapeutic window. Dose, timing, and duration, these things matter. And finally, review. Nothing should be set and forget. Everything needs to be reassessed against outcomes. This slide shows how we think about medications and supplements as interventions in the context of longevity medicine. At the base are non-negotiables: sleep, nutrition, strength training, aerobic capacity, and stress regulation. Above that, correcting deficiencies. For example, iron, B12, vitamin D, measured and treated. Then we've got risk-modifying medications, for example, lipid-lowering agents, antihypertensives. These are medications with strong outcome data. Then we have disease-specific therapies, for example, GLP-1s, SGLT2 inhibitors, hormone replacement, all when indicated. And finally, we have experimental adjuncts, things like peptides, NAD precursors, where the evidence is evolving and uncertainty remains high. We don't replace behavior with molecules. We build a foundation first, and then we layer interventions deliberately. Again, when the base is strong, everything else works better, and often you need less of it. And this is where supplements actually have a role, but it's a narrow and well-defined one. First is a measurable deficiency. If there is a confirmed biochemical gap, iron, B12, vitamin D, and it can't reliably be corrected through diet alone, then supplementation is appropriate. The second scenario is a high turnover state. There are periods in life where physiological demand exceeds what can reasonably be achieved through food. Elite training, pregnancy, acute illness. In those situations, supplementation can support the system, but it's still targeted and time limited. Third, and this one's important, it's a food first approach. This has to already have been attempted and failed. Not assumed, not bypassed, actually implemented, monitored, and shown to be insufficient. And finally, strong evidence. We're looking for interventions supported by randomized trials or meta-analyses. These demonstrate a clinically meaningful outcome and not just a biochemical change when we try to extract sources of bias. And the common theme here is precision. We're not adding supplements just in case. We're solving and preventing defined problems with defined indications. Now, supplements don't make sense, firstly, when we see red flags, such as when the marketing exceeds the evidence. And for better or worse, this is actually where most of the real-world use sits. If the primary driver is a podcast, influencer, or a trend, rather than clinical data, that's usually a sign to pause. Secondly is when cost outweighs the benefit. A lot of these interventions offer marginal, theoretical, or surrogate improvements, but they're priced as if they deliver meaningful clinical outcomes, and that mismatch is important to identify. Third, and most important, is safety signals. If there's any credible indication that there's harm, neurological, hepatic, renal, hormonal, cardiovascular, the threshold needs to be there to stop. And these are sometimes not benign interventions, even though they might be labelled as natural. And finally, when lifestyle does it better, if the same outcome can be achieved more effectively and more safely through sleep, nutrition, training, and weight reduction, then that approach should be first line. So in practice, this slide probably applies to the majority of supplements patients are taking. And the role of the clinician is not just to prescribe, but it's actually to de-prescribe where appropriate and redirect effort toward higher value interventions. When patients ask about supplements or newer therapies, the key issue is how confident we can be in the evidence behind them. And that confidence comes from where the evidence sits. Now, at the top of this pyramid are the highest level studies. These are called the randomized controlled trials and meta-analyses. And they give us the most reliable information because they measure outcomes across large populations and they're designed to reduce bias. Below that are large cohort studies, and these can show associations and trends over time, but they don't establish the same causation in the same way, and they have more risk of bias. And then right down the bottom, we have human studies. Often they show some signal, but vary in their size and effect size. Below that, we've got animal data, and that's important for understanding the theoretical rationale, but doesn't always reflect what happens in humans. And at the base, we have the lowest level, which is anecdotal reports. So when something makes biological sense or it appears to work but hasn't been shown in human studies, that's where they sit, and that's not a great level. But by the same token, we have to be practical. We don't need to end up with paralysis by analysis, especially if something appears safe and it might be effective for the individual. It can be worth considering. Many longevity supplements do sit in these lower tiers of the pyramid, and in clinical practice, we aim to base these decisions on the highest level, balanced with the preferences of the patient and the safety profile of the agent. To make this more practical, it helps to group molecules into broad categories, because not everything we prescribe or consider sits in the same space. On the left are supportive agents. These are things like supplements or ergogenic aids. They tend to have smaller effect sizes, and their role is usually to support physiology rather than drive major clinical change. In the middle is clinical pharmacology. These are the medications with defined indications. We're talking about metabolic therapies, cardiovascular risk modifiers, and agents that affect sleep or neurochemistry that have all gone through clinical trials and proven safety. And this is where we have the strongest evidence for meaningful impact and health outcomes. On the right, we have advanced or adjunctive therapies, things like hormones, biologics, neuroregenerative therapies. And while they can be powerful, they're also more complex and context dependent. Their evidence is still evolving in many ways. We'll go into each of these to understand their place in longevity medicine. If we narrow down supplements that tend to be more useful in practice, this list is actually quite small. We'll start with creatine. Creatine has consistent evidence for improving strength and lean mass. It's generally well tolerated across age groups, and there's emerging interest in the cognitive effects, particularly in aging populations. Omega-3 fatty acids sit in a more mixed space. There's some support for cardiovascular and anti-inflammatory effects, particularly at higher doses and in selected populations. Routine use at smaller doses tends to, of course, have a smaller impact. Vitamin D is very much a deficiency-driven intervention because if levels are low, replacement is obviously appropriate as it's an important hormonal signalling agent. Measurement first is important because additional supplementation in people with normal hormone levels doesn't help much. Protein is slightly different. It's really a nutritional tool. People who aren't meeting intake targets can be benefited by supplementation to support muscle protein synthesis, especially alongside resistance training. Magnesium is commonly used for sleep and muscle function, and while some patients notice benefits, it's generally small and modest in its effect size. So it's worth recognising that even things with lower tiers of evidence can be used in these higher output individuals. Iron and B12, really these are critical for neurotransmitters. And again, we like to confirm there's deficiency before supplementing these. So even within this group, the common thread here is specificity on how we use them. And this group reflects what many patients are currently exposed to, but may not actually be effective. So we start with rapamycin. And there's some really interesting mechanistic work in animal data, but we don't have long-term human trials. And it does carry meaningful immune suppression risk, so the margin for error is small. NMN and NAD boosters, they sit in a similar space. There's biological plausibility, but the human outcome data is very limited. And at this stage, most of the claims extend beyond what the evidence supports, and it's often broken down in the gut. Green powders are widely marketed, and from a practical perspective, whole foods remain much more reliable and cost-effective to achieve nutritional adequacy. Resveratrol, well, it generated a lot of early interest, particularly in lab and animal studies, but in human studies, the effective realistic doses have been very underwhelming. Curcumin formulations are often promoted for inflammation. Bioavailability is a big limitation, and even with modified formulations, the clinical effect size seems to be modest. And finally, testosterone boosters. These over-the-counter products don't meaningfully increase testosterone, and in fact, there's concerns around contamination with androgenic substances, particularly in athletic populations who may be tested. So this is a category where careful review is important because the expectation often exceeds what the data can support. Now, moving into medications. This is where we tend to have stronger outcome data and clearer indications. Statins are a good example in higher risk populations. These medications reduce cardiovascular events and mortality over the long term. The magnitude of the benefit is closely linked to the baseline risk and the degree of ApoB reduction. There's several large trials, including ASCOT LLA and Jupiter, which were stopped early due to clear reductions in cardiovascular events, reflecting the strength of the treatment effect. And from a mechanistic perspective, statins do reduce LDL cholesterol and ApoB, lowering the burden of atherogenic particles. And this translates into consistent reductions into major adverse cardiovascular events across large trials and meta-analyses. But as with any therapy, the decision to prescribe it has to be based on indication, patient context, and the balance of benefit and risk. Antihypertensives have a similar well-established benefit. Blood pressure control translates into reductions in stroke, heart disease, and renal complications. Metformin is used in selective metabolic phenotypes. It improves insulin sensitivity, and there's ongoing interest in broader applications, although that remains under investigation. GLP-1 receptor agonists have had significant impact in obesity and metabolic disease. They produce meaningful weight loss and improvements in cardiovascular risk markers. SGLT2 inhibitors have strong outcome data in heart failure and chronic kidney disease, with benefits seen across a range of patient groups. And DORAs, dual orexin receptor antagonists used for sleep, provide another example of a targeted mechanism by reducing wakefulness and improving sleep maintenance without some of the dependency risks seen in the older agents. So within pharmacology, each agent has a defined role, and the decision to use it is based on the indication, balance of the expected risks and benefits for the patient in front of us. Hormones sit in a slightly different category and require a more disciplined approach. The principle is straightforward. Replacement when there is a proven deficiency. Starting with testosterone. This is indicated in confirmed primary hypogonadism. It's not for body composition or performance in individuals with normal levels. Thyroid hormone is prescribed when there's a clear biochemical indication. Management of borderline or subclinical cases can be a bit more nuanced and often requires endocrinologist input. And menopausal hormonal therapy, including estrogen and progesterone, is used for symptom control, but it has additional benefits for bone health and cardiovascular risk in appropriately selected patients. And across all of these, the focus remains on treating a defined clinical problem with monitoring and follow-up built into care. I'll just emphasize here that hormonal therapy is not prescribed for anti-aging. That framing comes from outside clinical medicine and should be a red flag to anyone seeking longevity-based healthcare. Biologics and regenerative therapies. This is an area that's evolving quickly and one where the expectations often run ahead of the evidence. We'll start with biologics. They include monoclonal antibodies and targeted immune therapies. And these can be very effective, but typically they're effective in specific disease states with clear indications. Outside those indications, the evidence base becomes much thinner. Then we have regenerative or orthobiologic therapies, things like PRP, bone marrow aspirate, and cell-based approaches. There's some evidence, but particularly in musculoskeletal conditions, that evidence is of variable quality and risk of bias, and outcomes depend heavily on the indication, the technique, and patient selection. And cost and regulatory concerns become more relevant in this particular space and need to be part of the discussion. The third category is emerging therapies, including exosomes and gene-based approaches. These are often marketed strongly, but again, the clinical evidence is still developing. The biological rationale can be very compelling, but it doesn't necessarily translate to better patient outcomes. So across all of these, the same principles apply. The use is indication specific. The evidence base is variable and evolving. The cost and complexity are higher than most other interventions, and we have to be mindful of the associated commercial conflicts of interest that creep into the equation with these. And importantly, a plausible mechanism does not guarantee clinical effects. So careful patient selection and clear expectations is essential in this space. Peptides. Not a week goes by where I'm not asked about peptides. These are short chains of amino acids, essentially small signaling molecules that the body already uses in many of its physiological processes. And they act as messengers. They bind to specific receptors and they influence pathways related to metabolism, inflammation, and tissue repair. That biological role is what makes them so appealing. And there's often a clear mechanistic rationale for how they could work. From a pharmacological perspective, most peptides are given via subcutaneous injection. If they're taken orally, they're rapidly broken down in the GI tract, just like dietary protein. And this subcutaneous delivery allows them to enter the circulation intact with a more predictable absorption and bioavailability. But from a clinical perspective, this is where things diverge. Most peptides used in performance or recovery settings lack high-quality human trial data. Mechanisms are often well described, but consistent clinical outcomes are not. BPC 157 and TB 500 are commonly discussed in this space. These are synthetic peptides that are promoted for tissue healing, particularly in musculoskeletal injuries. Most of the data supporting them comes from animal and lab studies. At this stage, we don't have high-quality human trials demonstrating consistent clinical benefit, even though they're very commonly used. And from a safety and regulatory perspective, they're not approved for clinical use in Australia. Product quality can vary, and there are ongoing uncertainties around dosing and long-term effects. We also know that the placebo effect is heightened in any medication that's given via injection when compared to oral intake. So while the interest is understandable, the current evidence and regulatory position does not support clinical use. There are exceptions. GLP-1 receptor agonists such as semaglutide and tirzepatide are peptides with strong outcome data, particularly in metabolic disease. These are used with established regulated frameworks set up around them, and that regulation is an important consideration. Many peptides sit outside the TGA approval scope and they're not legally prescribed in Australia. And that introduces variability in the quality, dosing and safety. So in practice, our position is straightforward. We prescribe within regulated pathways using therapies that support meaningful clinical outcomes and that have evidence backing them. And if a therapy doesn't meet those standards, it doesn't form part of our clinical care. Vaccination is one of the most effective preventative interventions we have, but it's often not framed within a longevity context. When we think about aging, we tend to focus on chronic disease, but acute illness plays a major role in accelerating that trajectory. An episode of influenza, pneumonia, or shingles is not just a short-term illness. That can really decompensate a person and trigger systemic inflammation, reduce their physiological reserve, and shift them into a steeper frailty curve. And from a clinical perspective, prevention here has a meaningful downstream effect. Reducing infection risk means reducing inflammatory burden, preserving function, and maintaining independence over time. In practice, we focus on a small number of high-impact vaccines: influenza annually, pneumococcal vaccination based on age and risk, shingles vaccination particularly from midlife onwards, COVID-19 in line with the current recommendations, and then risk-based vaccination including hepatitis and HPV, depending on individual exposure and history. By preventing and reducing the severity of common infections, vaccination supports longevity intervention, and for many, it's an important part of our toolkit. Metabolic agents are increasingly central in longevity medicine. They target some of the most important drivers of chronic disease: insulin resistance, adiposity, and cardiometabolic disease. But of course, they're not population-wide interventions. Their value depends on selecting the right patient with the right phenotype. We'll start with metformin. Metformin improves insulin sensitivity and activates AMP kinase pathways, which has led to interest in potential longevity effects. That signal is still being explored, including in the TAME trial, but at present its role remains primarily within the metabolic space. GLP-1 receptor agonists are a different category. These are combinations of peptides normally produced by the gut that signal satiety and reduced hepatic glucose output, engineered to last days rather than a couple of hours. They've got robust outcome data, not just for weight reduction, but for cardiovascular risk reduction in patients with metabolic syndrome and for significant improvement in glycemic control with type 2 diabetes. They're one of the few areas where we have clear, clinically meaningful benefits across multiple endpoints. SGLT2 inhibitors have also changed practice significantly. These agents reduce glucose load on the body by allowing the kidneys to excrete glucose in the urine. But their benefits extend beyond glucose lowering, particularly in heart failure and renal protection in patients with diabetes, for which it's indicated. But interestingly, those effects are seen even in patients who don't have diabetes. And then we have acarbose, which inhibits the enzymes in the gut that allow it to slow carbohydrate absorption. And this blunts postprandial glucose spikes. This can be a useful agent in selected insulin-resistant phenotypes, particularly where glucose variability is a key issue. So while this class of medications is all highly relevant, their use needs to be deliberate, phenotype-driven, and goal-oriented. In lipid management, ApoB is the primary target as the main carrier of cholesterol particles that can enter and be retained within artery wall. What we're trying to do is to reduce the total burden of these atherogenic particles and, importantly, keep that burden low over time. And this is one of the areas in medicine where the causal relationship is very clear. Lower ApoB, lower cardiovascular risk. From a therapeutic perspective, we have multiple agents with different mechanisms, and they can be combined when needed. We'll start with statins. These remain the foundation. They have the strongest outcome data we have, with consistent reductions in major adverse cardiovascular events across large meta-analyses. Statins seem to have benefits above and beyond lowering of ApoB, but they have known risks of causing muscle pain, and in some patients, the data shows they can also lead to increased risk of diabetes, particularly in patients who are already pre-diabetic. Ezetimibe is typically the next step and is usually well tolerated other than occasional GI upset. It reduces intestinal cholesterol absorption and provides an additive effect when combined with statins. The IMPROVE-IT trial demonstrated that this translated into improved outcomes, not just lower numbers. Now, for higher risk patients, PCSK9 inhibitors can be considered. They're expensive and they can have injection site reactions, but they allow a substantial addition of reduction of LDL and ApoB, often in the range of 50 to 60% on top of statin therapy. And importantly, that reduction again translates to improved cardiovascular outcomes. The next one is bempedoic acid, and this is a useful option, particularly in statin-intolerant patients because they use a different pathway, but they can increase uric acid, and there's a small signal for tendon-related issues. It acts upstream of statins via a different pathway, as I mentioned, and this can reduce some of those muscle side effects. The CLEAR outcomes trial showed a meaningful reduction in cardiovascular events in that population. And finally, Lp(a) targeted therapies. These are emerging with very large reductions in Lp(a) levels, but we don't have long-term safety or definitive outcome data yet. And it's likely to become an important option for these high-risk patients in future. But because all of these lipid-lowering medications are often long-term medications, whenever we're considering prescribing them, we want to be confident that we've explored all options over a period of months. And that means working with the patient on shared decision-making so we both have clarity that the benefits outweigh the risks for them in order to achieve and maintain that low ApoB burden over time. And because statins are just one tool within our armory of preventing atherosclerotic plaque formation in selected patients, we like to help our patients understand their options. And this reference table is just one of the tools we use to help clinicians and patients understand the reasoning between the different choices of statins, when they're used, whether they cross the blood-brain barrier, how they interact with other agents, and their effect on ApoB as well as tolerability. But pharmacology continues to make advances, and statins are definitely not the only option, as we've seen. And here's a reference table that I often discuss with patients in terms of the range of agents we now have in modern medicine to manage dyslipidemia, ApoB, and therefore atherosclerotic cardiovascular risk proactively. When we talk about longevity, we often focus on cardiovascular and metabolic risk, but structural integrity matters just as much because without adequate bone density and muscle mass, living longer often means living with reduced function, increased frailty, and of course higher injury risk. Agents in this space will start with creatine. This is one of the most well-supported supplements we have. It improves power output, helps preserve lean mass, and there's emerging evidence for cognitive benefit. Importantly, it has a very good safety profile when used appropriately, but we would always ensure renal function is adequate, particularly in patients with pre-existing renal disease or risk factors. Calcium and vitamin D are a bit more nuanced. They're important in the context of deficiency, but population studies have shown that high-dose calcium supplementation in isolation may actually carry higher cardiovascular risk. So this is about targeted replacement, not blanket use. Collagen with vitamin C is more specific. There's some evidence supporting its use in connective tissue, particularly when timed before loading, and there are a number of studies from the AIS demonstrating improved tendon remodeling. So this is most relevant in tendon and ligament rehab. Protein supplementation is often practical. Many patients simply don't meet the protein requirements needed to support muscle and bone protein synthesis, especially when training or in older age. So supplementation helps close that gap and helps active patients achieve improved structural resilience, usually aiming at 1.6 milligrams per kilogram per day. And finally, anti-inflammatories or NSAIDs like diclofenac, ibuprofen, celecoxib, and so on. Well, these have a role in the short term to manage inflammatory joint and tendon conditions that limit exercise capacity, but chronic use is problematic. Counterintuitively, it can blunt training adaptations and it carries GI and renal risks. So these supplements are less about metabolic optimization and more about maintaining the structural capacity and repair mechanisms to support everything else we're trying to achieve. When we think about neuroprotection, it's easy to focus on supplements and emerging therapies, but the strongest evidence still sits with lifestyle interventions. On the evidence-based side, exercise, of course, is the most powerful modifiable factor we have. It improves cerebral blood flow, supports neuroplasticity, and consistently it's associated with reduced dementia risk. Sleep is essential. We know that amyloid clearance occurs during REM sleep in particular, and chronic disruption appears to accelerate neurodegenerative processes. Once dementia is diagnosed, all the advanced treatments we have to remove amyloid only have a very limited and modest effect. And blood pressure control, well, this remains fundamental, reducing stroke risk and limiting small vessel disease and white matter change. Anything that affects endothelial health increases vascular and dementia risk. So optimizing patients' endothelial health beyond blood pressure alone is going to be important. And lastly, omega-3, particularly DHA, plays a structural role in neuronal membranes, and there's some evidence for slowing cognitive decline, particularly in deficient or higher risk populations. But again, the evidence is not of high magnitude. On the other side, we have a range of therapies that are widely discussed, And there are always more and more investigational medications in this space. Things like lion's mane, NAD boosters, and broader nootropic categories all have plausible mechanisms, and broader nootropic categories all have plausible mechanisms. But at present, human outcome data, particularly for cognition, is limited and inconsistent. Now, that doesn't mean there's no role in the future, but it means they shouldn't displace interventions with established benefit. In practice, the fundamentals still outperform everything else. Sleep and exercise remain the most effective neuroprotective strategies we have. When we talk about cancer prevention, there are relatively few interventions that have clear, reproducible outcome data. And importantly, these are not supplements within the traditional sense. They're targeted evidence-based interventions used in the right patients. We'll start with vaccination. HPV vaccine, it's one of the most effective cancer-preventing tools we have. It reduces the risks of multiple cancers, cervical, oropharyngeal, anal, and it remains underutilised, particularly in adults. Similarly, the Hep B vaccine plays a clear role in preventing hepatocellular carcinoma in at-risk populations. Aspirin is more nuanced. There's evidence for colorectal cancer risk reduction, particularly with longer-term use. But this needs to be balanced carefully against bleeding risk, so patient selection is critical. And vitamin D is often discussed as well in this space. Again, it's an important hormonal vitamin, and the strongest signal around its use is deficiency. There's some association with reduced cancer risk, but it's not a case of a high dose and indiscriminate supplementation. And then we have nicotinamide. This is one of the more practical interventions that we've got in dermatology. It has good evidence for reducing non-melanoma skin cancer recurrence in high-risk individuals. Again, we aim for targeted evidence-based use of these agents rather than indiscriminate supplementation. Polypharmacy is a major issue in our society and usually represents increasing medication complexity without a clear incremental benefit. Every additional molecule increases interaction risk, it increases monitoring burden, and it raises the probability of unintended harm. In real-world practice, risk tends to accumulate in predictable ways. Combined supplement stacks, particularly fat-soluble vitamins and herbal agents, can also lead to unrecognised excess and interaction effects. Compounded peptides introduce another layer, variability, of course, occurring in the sourcing, dosing and quality. And then when hormones are added into that mix, like thyroid, testosterone, cortisol pathways, the interaction landscape becomes even more complex. And over time, there's a cumulative metabolic load on the liver and kidneys that often isn't appreciated. So the goal is not to add more, especially not in the long term. The goal, in fact, is to reduce complexity and use fewer agents with greater precision, even if that means deprescribing medications. So this framework only works if the decisions behind it are disciplined, because not every abnormality needs to be treated, and not every available therapy improves outcomes in a meaningful way. The first step is separating signal from noise. We generate a lot of data, bloods, imaging, wearables, but only a subset of that actually changes clinical risk in a meaningful way. The next is the magnitude of the effect. A statistically significant change is not the same as a clinically meaningful one. We're looking for interventions that move risk in a way that matters over years, not weeks. Then we've got risk and burden. Every intervention carries a cost, biological, financial, or behavioural. And even low-risk therapies can become problematic when layered together. And finally, patient context. What matters to the patient, what they can realistically sustain, and where are they in their life are all questions we need to ask, because adherence and consistency will always outperform theoretical optimization. So this is not about doing everything indiscriminately. It's about doing the right things at the right time for the right patient. Okay, what I want to do now is bring this framework into practice. These are 4 real-world case studies across athletes, metabolic health, sleep, and lipid management. Each case represents the same principles but applied in different contexts. And across all 4, the theme was consistent: clarity of indication, measured intervention, and ongoing monitoring. This is one of my more memorable patients. This case demonstrates how RED-S, or relative energy deficiency in sport, can present outside the typical population. A 50-year-old masters athlete, highly disciplined and who was following a long-term plant-based diet, presented with bilateral sacral stress fractures. And this is an abnormal injury pattern. It's a clear red flag for low energy availability. When the body is low in energy, it prioritizes its core functions and deprioritizes things like fertility, hormonal signaling, and bone remodeling. On further investigation, it showed he had reduced bone density on his DEXA scan with suppressed testosterone and growth hormone. He subsequently sustained a spontaneous rib fracture during his recovery, and this was really confirming that it was a systemic issue rather than a specific injury. As a team, our management focused on an overhaul of both substrate and stimulus for tissue repair and remodeling. With the dietitian, a depth of education was provided, and he was given a structured fueling strategy along with adequate total energy intake and protein sufficiency included in that. Calcium, vitamin D, and creatine were introduced as supports for him. And with the exercise physiologist, his training was modified. The endurance loads were reduced with progressive introduction of strength work, and he tolerated this very well. With the endocrinologist, anabolic bone agents were introduced to assist with his recovery from low bone mass. This gentleman's progress was tracked with every 3 months, having bloods and a repeat DEXA, and he was focused on improving his lean mass restoration and his hormonal recovery. He understood the importance, and by 6 months he demonstrated a significant recovery with both improved performance and speed on the bike and with running at a higher body mass. He was more powerful, and his bone mass also improved significantly. This case highlights the mismatch between high output and insufficient input. This case highlights the mismatch between high outputs and insufficient inputs, and we need to be wary of these in our most highly motivated athletes. This was a high-functioning 55-year-old executive who described a gradual decline in his metabolic health over several years and was actually referred by his cardiologist. He had a progressive weight gain, increased visceral adiposity, and dyslipidemia. And although he was asymptomatic, once again, he was referred by his cardiologist with suboptimal coronary health. The assessment revealed a pattern of elevated ApoB, increased visceral fat, and features consistent with MASM. Since COVID, his alcohol intake had gradually and insidiously increased to over 20 standard drinks a week. The management was structured and layered. With the added input of his cardiologist, lipid-lowering therapy with PCSK9 inhibition using medication called inclizumab was introduced, but behavioural change was the primary driver for him. His alcohol intake was reduced, meal quality and carbohydrate intake tightened with the dietitian's input, and his training was restructured with the exercise physiologist to include high-intensity intervals and resistance work. Progress was tracked through the ApoB and visceral fat, with significant improvement in just 3 months, consistent with reversal of MASL, loss of over half his visceral fat, and a complete reclassification of cardiovascular risk. So the pharmacology supported this process, but this gentleman's behaviour change drove the outcome. This case involved a 34-year-old healthcare practitioner and endurance athlete recently diagnosed with ADHD and commenced on Ritalin. The initial response for him was strong with improved focus and productivity. However, sleep disruption and appetite suppression led him to have an emerging energy deficit and fatigue. This reflected a system imbalance rather than treatment failure. The management then focused on stabilisation. A dual orexin receptor antagonist, DORA, was introduced on days where Ritalin had been used as needed to restore sleep architecture. This resulted in improved sleep quality, stabilised energy, and maintained cognitive performance. Ongoing management included careful titration and strategic drug holidays both through the week and through the year to maintain the balance between cognitive and physiological demands. This case highlighted how treating one system in isolation can create dysfunction elsewhere. And the last case involved a 55-year-old woman post-menopause with insidious weight gain. She had musculoskeletal limitations and significant insulin resistance. She had only been performing Pilates and walking for exercise over the last several years, but was managing significant back and knee pain as well. Her lipid profile was very abnormal, and she had an incidental diagnosis of an anomalous coronary artery, placing her at higher cardiovascular risk from baseline. She also had elevated visceral fat and features of marked insulin resistance on her DEXA and bloods, respectively. Statin therapy was indicated, but it wasn't tolerated, with multiple attempts limited by myalgias and arthralgias. So for this lady, ezetimibe monotherapy was initiated at a low dose, was guided by clinical reasoning despite limited high-level evidence in her specific context. And this was alongside insulin sensitization strategies, including the introduction of resistance training and a lower glycemic diet that resulted in significant reduction in visceral fat and improved muscle mass over 12 months working with the exercise physiologist. Her outcomes were tracked during this time, and she tolerated treatment very well, including significant improvements in ApoB, body composition, and visceral adiposity. Her coronary imaging also remained very reassuring, with no evidence of interval plaque formation. And this case illustrated why the gaps that can exist in the evidence need to be filled with practicality and rational clinical reasoning when there's no ideal data to base decisions on. If there's one idea to take away from this, it's this. Molecules have a role, but they have to earn their place. Sleep, movement, nutrition, and stress regulation remain the foundation. Molecules are layered in then to support those systems when clinically appropriate. What they can do, when used well, is to support biology at the right time, in the right patient, for the right reason. So the standard we aim for: clarity before prescribing on the risks and benefits and the patient context. Evidence where it exists, active monitoring and integration into long-term behaviour change. And that's ultimately what we're trying to build: holistic systems that work and continue to work over time for each individual. All cases presented today have been de-identified and modified for educational purposes. The management approaches discussed reflect clinical reasoning within a specialist context and are not intended as individual medical advice. No patient-doctor relationship is established by viewing this material, and treatment decisions should always be individualised based on patient-specific factors and aligned with current clinical guidelines and scope of practice.